Thank you.
You're welcome.
Good morning, everybody. We always take these opportunities to kind of cover some topics or concepts in addition to having an open forum for answering questions, both that were pre-sent in as well as during the actual event. So this will just be a few minutes of some things that we've talked about before in this forum, as well as that are regularly discussed at our medical advisory committee meeting, as well as our health council meeting. So some of these topics you may have heard of before, but and some of them are loop closure on them. So we're going to talk about the IALS or intermediate ALS dispatch criteria. We're going to talk about bloodborne pathogen exposures, CARES data, and then the Commonwealth protocols. So first, on the IALS dispatch criterion, we have made significant progress. So just as a reminder, our process is that if we want to make a change to these criterion cards, we have to first develop it and review it with the Emergency Communication Center. Then we have to vet that with the Medical Advisory Committee before then finally going back to have them approved by APCO. So we now have these 4 criterion cards done. And remember that we decided upon these for a couple of reasons. One was how often how often these dispatch types were frequent in terms of call type. Second was that these were seen as opportunities for intermediate advanced EMTs, intermediate ALS units to be able to manage them in a safe manner. And then third, it allowed us to kind of work on how these criteria would work moving forward into other dispatch types as well. So we tried to create it in a way that it involved medical and trauma. So we have diabetic, overdose, sick unknown, which would become the ATRAN or ITRAN in this case, and then falls. The guiding principle in this has always been put the patient at the center, make sure that it's safe and appropriate for our patients. Remember that criterion-based dispatch cards typically over triage, and that is acceptable, just as we often over triage in many of the things we do. You know, we assume chest pain is an MI until we prove it's not. We assume a patient who is intoxicated and falls has a head injury until proven otherwise, things like that. So what you'll see, these are conservative, and they're purposely conservative. But as you can see now, each of these has a section which is the IALS criterion. So what's going to happen is the dispatcher is going to review it. If the next available unit, if the first up unit available is an IALS unit, historically that would have gone ALS, but if they meet the IALS criterion, they'll dispatch the IALS unit, and then they will independently manage that incident without an incoming ALS unit. Obviously, if information were to change, or if they get on scene and identify that they need additional resources, they'll then call for an ALS. So where we are now, these have been reviewed by the Medical Advisory Committee. We're going to send out before the end of this month for final comment and approval. Barring any problem there, which I don't anticipate any, these will then be finally reviewed with APCO. If we get their approval, then hopefully first quarter of 2024, we'll be able to start training our dispatchers as well as our providers on these criteria. So our plan is that we will run this for a pilot for a year. Barring any challenges, we would then simultaneously be looking at, are there other cards where it's appropriate to look at additional IALS criteria. Honestly, this is a huge workload. This is not a simple process, and it requires obviously a multidisciplinary approach. So I will stop there on the IALS dispatch criterion. Does anybody have any questions, comments, thoughts about that, either from the office, anyone in the room, or anyone on the virtual meeting? Very good. So one of the areas that we've been very passionate about is the safety of our first responders. This is all first responders and the risk of bloodborne pathogen exposure. So we talked about this extensively at our medical advisory committee meeting. there was a resource letter that went out from the region, from me to agencies as well as hospitals to just remind people about expectations around bloodborne pathogen exposures. And here is the scenario: is that a first responder gets a potential bloodborne pathogen exposure. What is the path that they should follow, right? Because there's multiple things they could do. They could do nothing. They could go to their defined occupational health entity, or they could go to the hospital where the patient, who's the source patient, goes as well. So, what we wanted to remind people of, and this letter came out and just reiterate here, is that it is the agency's responsibility to have a defined infection control officer. So that person has to be defined ahead of time. They need to have additional training in order to be in that position, and really should be the first line of defense for a first responder to know whether they've had a significant bloodborne pathogen exposure or not, and what to do next. What we've identified is that most EMS agencies have somebody. However, a lot of our fire and police agencies had no such person. And we encourage them to work on that. The second is that hospitals do have a duty to act when they have a patient who's a source patient, in terms of notifications for a whole host of different things, not just things like HIV and hepatitis C, but even things like COVID and so forth. And we wanted to remind hospital designees, specifically the emergency department leadership, on this task. Remember that the Ryan White notification law does allow for a couple of things. One is that a first responder who is exposed in the line of duty can be notified if they meet certain criterion. A, that a physician or healthcare practitioner has identified that it was a significant exposure, and they agree to testing testing and baseline testing as well. They can be notified of the results of that source patient. OSHA 1910 clearly defines not only the obligations of the employer, whether it's volunteer or compensated, but also of the hospital in notification to somebody. Our best practice recommendation is that if a first responder has an exposure, they should go to the hospital that the source patient goes to. There is no mandate that you go to an occupational health site or an urgent care. Many times they will be able to do nothing for you except for say, we can take your blood here, but we can't obviously test the source patient. If you go to the hospital where the source patient goes, they can do a rapid assessment of the HIV status of that patient, generally within 90 to 120 minutes. That will allow you to make an informed decision around should you use antiviral prophylaxis, as well as obviously other potential risks for hepatitis B, hepatitis C, and the like. So we believe that that is the best plan. The regional office always has somebody on call. We remain an option for any first responder, primarily the infection control officer or chief officer, to call us if there's a question about what should we do, where should we go. We can help navigate that. Director Luce and myself were involved with one recently where we actually had to involve the coroner's office and go down a path of having the coroner's office perform post-exposure testing on a source patient. So these are complex things, and the best place to always do it is going to be if that source patient goes to a hospital, going to the hospital with them, meaning that the first responders should go there. We encourage our hospitals to see those first responders rapidly and to perform rapid testing on the patient if appropriate, meaning if it's defined as a significant exposure. Questions, comments about that item?
Who's going to be notifying after the fact? Accident occurs and 2 weeks later they find that the person's got meningitis. And
so complex question, right? So it would require that, I think it's much easier if it happens in the first 24 hours than a patient arrived by EMS. Every hospital infection control team has a methodology that they go through for how somebody got to the hospital and trying to define. But I think it's easy for EMS because they get a patient care report.
Right.
Much more complicated for other first responders. So I think each hospital would have to answer that question.
okay.
So I wanted to just briefly talk about the CARES data. Remember that CARES is the national database that allows us to monitor out-of-hospital cardiac arrest care. And it's really one of the ways that we can look at how we rank locally, statewide, as well as nationally in the care that we provide. And I'm just going to briefly talk about this, but what I will tell you is that a couple of things. When we're looking about value-based care, what we bring to a community, what we bring to a health system, this is one of the few evidence-based databases that is out there. And if agencies don't coordinate their data into the CARES database on a regular basis, or hospitals don't do the follow-up, those cases don't get entered here. So we know with 100% certainty that there were way more than 321 cardiac arrests in Bucks County in 2022. However, either an agency did not complete their part or a hospital did not do the follow-up. When that happens, it's thrown out of the data set. So what that means is we could have much different information that we see represented here. So my first point is that for agency leadership, you should be making sure that you have a reliable process for entering this data into the CARES database. It's not a ton of information, and it's quite honestly pretty quick. Also, you should have a relationship with your hospitals to be able to make sure that they're doing the follow-up. The follow-up piece is not that difficult. Actually, the most difficult part about it is, trying to connect which patient, especially if they arrive as a DOE, to try to backtrack to where that patient is. But the actual follow-up, having done it personally on the hospital side, takes a few minutes once you identify the patient. When cases get thrown out, we lose that value. And I will tell you that as insurers look at who they're going to give money to for care, one of the things they look at is the value-based care proposition that we bring. And if we can't show things like this, it puts us in a bad place. So I will start with that to say, if you're an EMS agency leader in your squad, you're either not sure or you don't enter your CARES data regularly, you should do it. And if you don't know whether your hospitals are closing the loop, and how you can find out very quickly is your CARES representative, and every one of us has one. If you don't know it, you should find out, and the office can help with that. You could ask them, are the hospitals closing the loop on our cases? If not, you should advocate to them to be doing that. So that all being said, I will, just give me, it took it out of context. Just click on a slide. Anywhere, just click anywhere once. There you go. Thank you. So here's kind of I'll cut to the chase. There's a ton of data in this report, but here's what it boils down to. And so I will first say that UTSTEAM cardiac arrest survival template is a validated way of looking at out-of-hospital cardiac arrest, right? Because there's so many variables. What UTSTEAM does is it boils down all of those hundreds of variables into a few key things. And UTSTEAM survival is defined as when it's a witnessed event, which is the highest chance of survival found in a shockable rhythm. And then bystander survival is when you add on to that the bystander did something. Could have been CPR, chest compressions, could have been applying an AED or the like. And then this allows you to normalize things, because we know that the unwitnessed cardiac arrest has the lowest chance of overall survival, where the witnessed cardiac arrest has the highest chance. So we focus our attention there. So our UTSTEAM survival, if you look at that, what you see here is that we are lower than both the Commonwealth at 34% as well as nationwide. So you have to ask yourself some questions why. So when you look at our data, we have a higher percentage of events being done at a residence, at a home, versus in a public place. And that probably impacts some of this. And then I will go back to my first point. We are not inputting all our data. We know that. So that because of that, if 10 more cases were in here, we might suddenly find a much higher survival rate. So again, it goes back to point one. If you're not taking part in CARES, you need to, if you want to be part of this system and help drive change, help drive funding. So the strengths of our data, right? So we're still above, what I would say the basement level is 20%, meaning that anybody that's a high performing EMS system wants to be greater than a 20% UTSTEAM bystander survival percentage. So we're above that. That's a good thing. But we could clearly be doing better. And again, whether it's data or whether it's our field care is a question. What I will say is we have one of the highest in the state of transport to the hospital with ROS. That could be transient ROS or actual persistent ROS. So it tells us that we are doing a good job of getting a potential perfusing rhythm back, but are we sustaining that? And so if you look at our strengths, again, some witnessed events, we do have good bystander CPR, and we have some sustained ROS higher than the national average. But what we see is that there's opportunities around AED access, telephonic CPR. So we know that our dispatchers do a tremendous job of encouraging CPR to be done. But how well is that CPR being done? We've all walked in on that code, and the CPR being done is maybe not as good as it could be. And how do we manage that? And then the third one, I think the most important, when we get ROS back, how aggressively are we managing that patient, right? Because once you get a pulse back, it's perfusion, 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 and making sure that they're not hypoxic. That's it. So how aggressively are we giving pressors? How aggressively are we oxygenating them to make sure that they're being well oxygenated? Because that could be part of our opportunity, right? We've all seen the case. We get a pulse back and everyone's like, oh, good, we're done now. And we're not. We're just beginning that journey. If we want more patients to walk out of the hospital alive, we need to make sure that they have a pulse when we are delivering them and that they're well oxygenated and well perfused. So I present this at a very high level just to say that this is something that we look at. I think it's incredibly important, and I encourage agencies and hospitals to take part in it.
Dr. Weiger, can I just comment on that post-resuscitation management? It's not about rapid transport. I think the important part is sometimes you have to stay and wait 10 minutes because that's one of the most vulnerable times after you get ROS back in the setting is they can rearrest if you start moving too fast. So sometimes, as much as we talk about extended on-scene times, you really have to manage the patient, kind of get them settled. Because that movement is our weakest time, our most vulnerable time for our patients when we're doing post-resuscitation care is when we go to move them because things can change automatically. And I think that is something we always struggle with. It's not so much is getting the vasopressors in it's more than that. It's just taking that time, go through your checklist, making sure everything was done and manage that patient for an extra 10 minutes on scene.
One of my QA mantras at my organization is the stair chair to heaven. That is a take, obviously, on the stairway to heaven. My point being is that sometimes we have very critical patients. We move them to the ambulance thinking that's the right thing, and then we lose that small window of resuscitation. And post-ROSC is a time where everyone should stop, take a look at what's going on. Do we have good access? Or how well are they perfusing? Remembering that a dose of epinephrine is going to wear off over 3 to 8 minutes. Are we in front of that? Are we giving pressors to make sure that they're not going to hypoperfuse? How well oxygenated are they? If a supraglottic airway is in, are they being well oxygenated? Do we need to move over to an intratracheal intubation? Those decisions should all be made before the patient.
Ryan, you should be able to take yourself off mute. I see you have your hand up.
Yeah, can you guys hear me okay? I had to use my phone. I apologize.
Yes.
Okay. I'm a little bit late, and maybe this would have been more appropriate for like MAC or CQI. Obviously, CARES has multiple levels to it, but for the provider documenting post-cardiac arrest, are we seeing in that drop-down tab when we say, hey, it was a code, are we seeing providers giving the correct amount of data? Jason, like, are you getting enough from that provider pool, or is there things that are consistently missing?
I apologize. I missed some of that. I was monitoring the screen, so I apologize for that.
I think the substance of it is how, starting at the front end, an EMS incident with a cardiac arrest, how well, when you look at the data, do you think that the data is being well represented and in that chart so that the agency can then put the CARES data in effectively?
Exactly, Dr. Weijo.
I think so. For the most part, the weakest part in documentation, I think, would be their assessment of ROS, as far as with meeting the definitions of it, and as far as a lot of times ROS will be documented as far as they had ROS, but if you read the narrative in the entire chart, they regained it and lost it at the time of destination, so they didn't truly have sustained ROS.
And
But up
then,
until,
go ahead,
fairly
I'm
decent.
sorry.
now, up until that point, I think it's fairly decent.
And then more so just out of academic curiosity, after like doing the new ALS protocol update, are we going to be looking, I mean, maybe this isn't the scope of CARES, but like the efficacy of norepi versus epi as like a vasopressor post-ROSC? Like, are we going to do a study locally or at the state level?
So I think there's probably pretty compelling evidence that norepinephrine is a superior agent to epinephrine for neuroprotective in the setting of post cardiac arrest. So I'm not sure a study needs to be done. I think there are challenges around administration of it, which make it different than epinephrine, as well as cost benefit, training, things like that. So I think that will be something that probably each agency will need to look at as we're moving forward.
Well, that was the shortcoming I saw, is that like, yes, norepi, like exactly what you said, but from moving in the back of the ambulance, even with that 10-minute stabilization, like I feel like the push dose pressor may be easier for most providers. You know what I mean?
Right.
So I was curious if we were going to kind of investigate that at the county level.
Yeah, I mean, I think for a whole bunch of reasons, those things are complicated. I mean, that would become a fairly complex study, which is hard to do with multiple disparate entities. That being said, there's a lot of good evidence out there about norepinephrine, but there's its ease of use in the pre-hospital setting is one that is a little more confounding. So I think a good conversation, as you said, for the medical advisory committee.
Okay. Thank you for your time, guys.
Thank you. So I'll just end with, on this topic, please, please, please enter your CARES data. And if you're a hospital, please, please, please enter your CARES data. And if you don't know who your CARES rep is, find out. And if you don't know, they email you all the time. And if you don't know, you can ask us and we can give you some assistance. Last thing is, many of you are probably as surprised as me that the Commonwealth protocols got released. They were not supposed to be, but now they're out. So I bring that just to say that this is important for a couple of reasons. One is that there's a new, obviously a new medical director for the Commonwealth who had a slightly different approach to it's just on a loop, Jay. So
Yeah, that's you doing it with the remote.
listen, I'm holding it like that. I think who had a different approach to the protocol. So I will just highlight that, you know, the training that's out there is valuable. There's been a lot of discussion on these things. So each of the protocols were updated, and I would argue some of them in very substantive ways. So the BLS protocols, I need to just randomly pulled out, but I think some of the most interesting. So there was a complete change in, the patient contact protocol to really try to be very prescriptive about how the date ends with a patient, meaning how do you define a patient, who's responsible for that patient, and then what has to happen. So I think this will, change the ability to say it was a police matter or no patient found will evolve because of this protocol. As you go through it, you'll see it's very prescriptive. On the ILS protocols, you'll see that now ketorolac, Toradol, has been introduced into a pain management protocol for our AEMT. So prior, it was not. It was on the approved medication list, but there was no protocol where it was allowable. So although it is still below the medical command line, they will be able to say, as per that protocol, I'd like to administer this dose of Toradol. That's much better for the medical command physicians because now they're not just shooting in the dark. It's defined by a protocol. And then protocol 8003 is the new protocol for the agitated patient. So we used to have two protocols, 8001 and 8002. One was agitated patient, one was for delirium with agitation, or agitated delirium, I'm sorry. Now those have been combined into a single protocol. And as you'll see, there are multiple options for sedation now, which has some benefits and also some risk to it. I bring those out to say these are just a sampling of what's out there. So the updates are out on the website. We certainly encourage people doing that. These an agency can go sooner, but, most agencies will probably choose January of 2024 for the go live. An agency that completes all the training, a medical director decides to go sooner, they could. And there's a lot of tidbits in here. So again, a lot wider use of droperidol as one example, not only for sedation, but for antiemetic. As Ryan had said, introduction of norepinephrine, and the list goes on and on. So I would encourage people to look at that. And more to come on this moving forward. But certainly an opportunity. They're out about, 6 months later than typical. But that was because of the change in leadership at the Commonwealth level. So encourage people to take a look at them. I think that the Commonwealth statewide protocols are some of the best in the country. They're evidence-based, they're well put together. And even with some of the bumps we had in this preparation phase at the Commonwealth level, I still think they're a very good tool. So questions, comments?
Are we planning on having a protocol rollout like we've done in the past?
Yeah, I know we're in the planning stages of that right now, but we haven't received the training, the modules for it yet. So once we get that, we'll put something out.
Probably in 2020.
No, it'll be before that.
Oh, well.
We'll do it in the fall. It's just
Yeah.
with the-
So, but I know we're meeting, there's been discussion within the office regarding a protocol rollout.
And then the protocols are posted on our website as well as in the Department of Health, obviously. And just remember about the element or the training classes for the rollouts before you're able to use them. Give me 1 second to kill this thing that Jerry was controlling the screen for and locking me out and everything.
Wow. We've learned from Larry, I can see.
Give the remote or did you?
I threw it out.
I had to take it away from him.
Don't give him buttons. He just pushes them.
Hey, you give me shoddy equipment, see what's gonna happen.
Yeah, the middle one there, that.
You're good?
Good.
There you go. Try to do better than Dr.
I
Wydrow.
turned off that part, but you should be okay.
So you didn't have faith in me.
Yeah, I did turn it off.
Can we do it this slide form or?
Outside scene in the regular slide, right?
No, I'm seeing that.
Okay.
Right there. That should
You
do
can
it.
do it now, so I can control it and move it.
Yeah, here.
That's good.
I need it as a teleprompter though. Again, I'll give my traditional report. This is a similar report that I give to, I've given to our MAC. I give it to our health council and also the Chiefs Association. I think the value in these town halls is so the general provider kind of knows the information that we put out on a regular basis. Again, this goes back to, I try to break everything down in the quarters so we can have, it's easier to match things up. And this is what our second quarter looks like. We're just finishing up the third quarter. So this is where our numbers are, and they've been relatively consistent. What I've seen a remarkable increase in is our percentage of transports. And the value of that is, and the reason I bring this up and I share this is because most of our agencies depend on, that is 80 to 90% of our revenue is what we transport. So every time I always struggle with is we got to reduce our call volume, but the problem with reducing call volume, it reduces our revenue volume too, because we don't have a sustainable ongoing revenue fund from our local municipalities. And I talk about this all the time to our municipalities. So it pains me every time say, oh, we got to increase revenue. Maybe if we do more calls, do we hear what we're saying? It's not like we work at Disney and we're trying to have repeat customers or draw people in, we're asking people to be sick and injured more often so we can provide the service that we need to provide on a regular basis. And again, this breaks it down over the years on where we're at for that same quarter. And again, everything has been pretty relevant. And normally we've always been in that like 69 to 72% of transport rate, but this is where we are as we move progress through the year. And this is just another comparison for quarter two, and this is the change. So we're up just less than as far as volume, we're up less than 1% of our call volume for the previous year. And that's where that's just focused on. But we have a 3% increase in transportation. So I think this will be our new normal in these numbers that right around 60,000 calls a year. These are our top 10 calls. These remain consistent dispatch types through the years. The one that changes kind of flip-flops every quarter is the unconscious and crisis psych transports. Otherwise, this is where we are predominantly. These are our top 10 dispatch types. And the important part is this is how a resource is decided on what gets dispatched to our calls. Our response times, again, relatively consistent through the years. The challenge is sometimes we have these outliers that really stick out and have changed some of our numbers. So I really focus, and this is all through the CAD, includes the out-of-county responses in. At the end of the year, we give every municipality what their fractile response times are. And that's what I want to make sure everybody understands. I don't like averages because it only tells 50% of the story. So our numbers look great when you look at an average. It'll look like, oh, we have 10-minute response times, until you have the person that says, hey, I got screwed. It took 14 minutes for you to get to me. Why did it take you 14 minutes? This gives us a better reliability. So it's that time or less within the county. And I think this is important to explain to people. I just did a meeting with 9 municipalities and told them, if you didn't have this EMS service there, your response time is going to go from 19 minutes to 30 minutes with high confidence level. Just to give a brief overview of our staff, instead of everybody doing reports, I just like to give a chunk of what we do, because a lot of people, we're busy doing a lot of nothing is the thought process, but these are some of the things that we do. Our training institute, our classes right now, in the second quarter, we had 31 start and 23 finish. People stop going to EMT class because it's hard. It's something different. And so it's become very challenging. Continuing education. I get questions all the time about continuing education, and this is where we are with continuing education. 51 courses were approved. Continuing education is just not a regional responsibility. We process the Con Ed, but what happens is we have probably 30 Con Ed sponsors. How many Con Ed sponsors?
Active, probably, yeah, 25 to 30 active.
But how many are credentialed? Probably 50.
Oh, yeah.
50 Con Ed sponsors and only 30 are active. So these are the ones that were just approved Con Ed by endorsement. Again, that process has changed remarkably, because a lot of people, some of the Con Ed sponsors were moving their responsibility to the provider, which I think is unfair. If you're a Con Ed sponsor and you want to be registered as a Con Ed sponsor, you have to fulfill your obligations, and that assists the providers. When the provider does Con Ed by endorsement and they live outside of our region, we're not sure what the Con Ed's looking at, because it's all reviewed by an individual. So the big changes with this right now is if you took a Con Ed class at a credentialed Con Ed sponsor, that they have to go back and re-register the class. And it's a lot of work for our office to do all that research. So we're down we've lost like 2/3 of the Con Ed by endorsement. At the peak, we were doing 600 to 700 Con Ed by endorsement forms. Each one of those applications has to be reviewed individually. And that's for people that are within our region. That doesn't include somebody that goes sends their Con Ed to Montgomery County, it may be viewed differently. Monco may view it as just one credit, you know? And that is the big challenge, is in order to have that consistency, it's important for our Con Ed sponsors to register the program. So if you take a Con Ed class and someone tells you, oh, just do Con Ed by endorsement, it can impede you. Our recruitment activities, and this is something that Ian is just growing. So we started EMT completion ceremonies for our program, just to recognize people getting through that program, getting to the end, and giving them that certificate. People go to our EMT class for a variety of reasons. Some of it is so they get the patient, they get the Con Ed hours needed so they can apply for PA school, a medical school, a nursing school, and add it to their college application. So using the venue and to do as an individual, we need a letter for this person. So this gives them a way in doing it, and we do it in a public forum. It's another opportunity for our EMS agencies to attend these things, these ceremonies, and try to recruit at the same time. We've always opened up our training classes that if you work with the instructor, that you can come in at a break and do more recruiting, because we have to be part of that recruitment that we never had to do before. So going to our classes, going to the ceremonies are opportunities. We also attend career fairs. The challenge with going to a career fairs and community outreach is it just puts EMS on the map. We're not employers, so we can't guarantee anybody jobs. But what we can do is, does it put an interest into somebody that is thinking about going to nursing school, thinking about doing any type of public safety, because EMS sits in the center of that circle. So if you have an EMS background, it kind of gives you a trial size, because I believe if you can do patient care in somebody's house with a dog and an angry family, you can do it in a hospital easily and much with less difficulty. So I think it gives people an opportunity, and what it trains, especially with our next generation workforce, if they don't have the social skills that we've all adapted to. And that's where we have to, this is why I'm kind of against hybrid classes, because we're in a people business and we need to learn how to talk to people and not text them. Because doing a patient assessment through a text does not work. Our licensure, this is what Gina pretty much does. This is what she does, what consumes some of her time. And every quarter it changes, but we're supposed to do these, we do these inspections, and it's just not going out, doing a check sheet. We have to review policies and procedures that are required by the EMS Act. And this is some of the requirements that the checklist that we report on. And again, we did safety inspections, and we're required to do a certain number of safety inspections. So when you see the office staff at a hospital, nursing home, dialysis center, wherever the case may be, doing those spot safety inspections, I think are important, because what we do, it's the only way we find people their accountability, because I know doing it myself, it's always so frustrating because people don't check their trucks, or they depend on the provider before them to say, truck's good, and then the suction unit's dead, or they can't find the suction unit. And these are important pieces of equipment. This is our leave behind program that is still quite active and still important. And I think, again, it's another thing that EMS does on a regular basis. And this is and we're very fortunate working with Bucks County Drug and Alcohol Commission. They provide us the Narcan. We manage the whole process and getting them out, replacing them for all of our agencies. Quality assurance. This is what Jason does. This is part of Jason's doing nothing. This is the chart review. And it just seems like such a small number. And in the grand scheme of things, it is. But when you sit there and you read every chart that meet these criteria and give feedback on, it's very time consuming. But these numbers are relatively consistent with what we've done over the years. And these are all mandated and reportable back to the Bureau of EMS. Along with that, there is value, because there's nothing like asking people to do things and not seeing the value, whether it's used or utilized or not. We do these longitudinal reviews, and that's from time of call intake until hopefully discharged from hospital and see the whole package put together. And it's remarkable, but extremely time consuming. So the numbers are low, but one of these calls can take, or doing these reviews can take days, weeks, just getting the feedback from our, not just our agencies, but also from our receiving facilities. Again, when we make these changes for the intermediate units, trying to fit them into our system, because they truly weren't designed for a suburban EMS. They were designed for rural EMS where you have extended response times. In our system, predominantly our intermediate units are in the southern part of our county, which has a heavy penetration of ALS units. So fitting them in, trying to find where they fit in a suburban EMS system is very challenging. And it's always not about what you're able to do, is making sure we have a good purpose for what you do. And that's what we always have to look at, and going through, like Dr. Roger talked about the protocols, we can't get into that room. We're going to do it just because we can. It doesn't provide the best patient care. We got to have a reason why. And I know everybody hates the whys and the justifications, but I do this on a regular basis. This is another QA reporting thing. We research every fatal car crash in the county and have to send that data back to the Bureau. And that's another thing. And then we have these required meetings that we're required to attend and participate in as a regional office. Just to give quick update, I've talked about it before. EMS received ARPA funding. Over the 6 months ago, they contract amendments because they weren't clear, because they included EMS, the nonprofit organizations we are, they grouped us with every other nonprofit, and they couldn't understand why ours so much higher. So doing a lot of debating and negotiating, I was able to get them to change it, because if all of our EMS agencies were employed by a government agency, the funding would have just flowed, no problem. Because I sat there and I looked at what people were approved for through the National League of Cities. It sounds like a made up group, but it's real. I was waiting to see Superman there, but it's a real system, and people were able to buy ladder trucks, engines, and stuff like that because they were attached to that government body. But our EMS agents are fulfilling that government obligation, and that was the debate I was able to use, and the county agreed. And that's how we were able to change a little bit of the contract. So that was approved, but we're still waiting. 6 agencies have had stuff waiting since January. And every week, what I can tell you, Kim and Audrey Kenny, the Director of Emergency Services, is talking to our, is it finance, Kim?
It's the controller.
The controller's office, to see when these are being done. And every time they tell us it's coming, I can assure you we are monitoring it on a regular basis because it's important. And to get these numbers is remarkable from the county. Some updates, and some of this stuff you were getting fresh off the press information because it's ongoing, and I wasn't able to give it down there last. So the paramedic program, again, they're almost there to approve. I guess we're on the cusp of the curriculum being approved on the 12th, and it'll be officially approved. The challenge is the program's going to be delayed until the fall because of the challenges of just getting the credentialing of the institute. So if it's approved in October, there's no way we can get COAMS accreditation. There's no way to get even the state accreditation. They said they thought they would be able to have it by summer. And I'm like, okay, have it by summer, but I want to start in the fall, just so we're matched up with the actual college semesters. And I think it's better if they have that target date and being ready to go in June, and then we can work out all the bugs, because I don't want to come back and have to work back. Well, it won't be my problem. Chris will have to come back and say Larry was wrong and have to work and walk everything back that I'm saying. So this is the challenge that we're dealing with. Exciting stuff is our EMT classes are relatively full. You know, to have 16 people in the percy class is remarkable. You know, and we as EMS providers have to embrace every one of these people. Because if you go in and not be part of the system in recruitment and retention, these are the people that have the potential in giving you days off, you know, and decreasing the mandatory overtime. And my experience over EMS is we get mad with mandatory overtime, but when overtime goes away, we're mad also. So again, it's the normal story. There's two things everybody hates, and that's the status quo and change. You know, and that's what we have to deal with. We're also running an EMR class up in Percy, and the reason that we're running these classes in Percy is I get funding for raw EMS education, and I'm limited to what I can do with it. So we're maximizing those funds to provide education in those rural communities. This is why we're doing our refresher class in Percy, is to utilize those funds and make it beneficial for everybody. And we're able to do it for a lower cost.
I don't know if it's related to the current, but Tipolito and Egan have their hands up again.
Okay.
Tipolito, if you want to go first?
Okay, thanks, Jay. Larry, I just wanted to point out, although that number looks good, 27 candidates, one thing, and Ian is aware of this, is more than half of the students in my Bristol class are taking the class for the sole reason of being eligible for firefighter EMT jobs. With that in mind, and I know it's a ways off, but I think the fire-based EMS, whether it be solely in a municipality or to support our existing EMS units, is going to be the only way we're going to be able to utilize these firefighter EMTs in a way that actually helps our EMS load. I have another question or point to make about, you had made a statement about our projections for call volume staying pretty steady. My question is, does that take into account the projections from the Bucks County Planning Commission? The reason I ask that is just here in Bristol Township alone, we have 4 old elementary schools are going to become age-restricted housing neighborhoods, and another development, a 4-story, that is also going to become age-restricted, may even be assisted living. So just in our little town where you think, you know, there's no more room to build anything, we're looking at about 600 units of age-restricted housing, which will certainly have an impact on our EMS volume.
I agree, and it's not, I think the numbers have stabilized, that we're not going to get this swing, the remarkable swings. It's so hard to predict, what the future truly looks like, you know, and our county is so diversified. So those numbers are global. Individual pockets will have more of an explosion. If you go to the, I'll call it the north central part of the county, where there's still a lot of land, and building 55 and older communities are rampant, I think is going to change a lot of stuff. I don't have the solution, and I do agree with what you're saying about the classes. It's hard to argue when you have municipal fire services, like Worcester Township just hired 3 firefighters at $65,000 a year. Our majority of our medics just started with a base salary of $70,000 over the last probably 2 years. And I'd love to get somebody recognize that, oh, we love EMS and we're going to give them increases, but it's just true economics, supply and demand. And that's how they've all gotten the increases in EMS overall.
Well, it's also easier to attract people to a fire EMS job. Whether, like us, we don't have ambulances. We only do certain QRS, go out and assist. But even looking towards the future, it's going to be easier for me to attract, recruit, hire people who are going to be firefighter EMS, even if they know they're going to have to do a rotation on the box. It's going to be easier for me to recruit than it's going to be for some of these rescue squads at the BLS level, because they know they're not on the box every day, every shift.
But it's more than that. It's the benefits and pay, because the majority of our EMTs are not even making $65,000.
Of course. Yeah, absolutely. It's just something that I at least recognize down here. And let me also say to everybody, Dr. Widro and everybody involved in updating those cards to take some of the load off our medics and allow the I units to pick up some of those calls. Thank you very much for your efforts.
Thank you, sir.
Okay, Ryan, did you have something while we're on the subject?
Yes, and it's actually kind of a perfect jump off from Kevin's point. Is the other thing with the EMT school is if you were to go on the AAMC medical website right now, which is pretty much like the guide to getting into medical school, the number one recommended path now to get clinical experience is to get your EMT. It's no longer being a scribe or something like that because financially it's better for the student. So between the concerns, like now we have EMT students that are taking up slots because they want to go to medical school or PA school or nursing school. And now we also have the fire department slot. Like how many of these providers are actually trying to become practicing EMTs? And I'd be interested to see if we could do a survey with the classes to kind of see where that data comes out at the start. And maybe we could try and figure out where like their shortcoming is or what we could do, or at least project, you know what I mean? How many of the 27 from Bristol are actually going to come out and be useful to us here in the county.
3 of them have interest, Ian.
Yeah, I, for the first time, because I've been involved with the Lower Bucks Tech School for the last 15 years or so. And for the first time last year was the first time that they had more people interested in EMS than fire and police. And
Yeah.
they're normally very police heavy.
I know I'm a graduate from, and I'm also on the OAC for them too. So like it definitely is trending more so, even from when I went through there, you know what I mean?
Yeah.
But I do feel like we're losing providers to, these other avenues. And I don't know if there's anything we can do to stop it, but if we could figure out a way to get more of them active, even if it would be like figuring out a bridge to a bachelor's program, that way they could get their bachelor's. I know this is a long shot, but like even doing a bachelor bridge, so that way they could do an accelerated post-bac for med schools and stuff like that. Like you could probably keep an EMT in the system for 3 to 4 years longer than what we're seeing now.
I think it's still a challenge because I'm going to be honest with you. The only happy public safety discipline is the fire service. Because I talk to police officers, they're unhappy and having similar struggles. I mean, we used to have police consortium tests that would have 400 and 500 people, and now we get 200 people sign up, pay $50 to take the consortium test, and 80 will show up. Or 160 will show up, and then 80 will finish the test. It's a struggle everywhere, and listen, we just need to work within our system, and I think our challenge is until there's sustained regular funding. I think it's always going to be a challenge as long as we're a third-party service, and this is throughout the country because there's metropolitan cities that subcontract their EMS out and have similar issues. Again, I guess this. People brought up some of the concerns, and again, we do that survey money asking what people want to talk about. So I always make an opportunity to talk about some of that stuff that comes in. So it's not we're just asking so we know what to prepare for questions. But I want to address some of this, and I did talk to some about this. Attracted EMS providers, it's a challenge, and it's ALS and BLS. We never thought we'd see the day that we would struggle just getting EMTs, and I think they've been underutilized in our system forever because there's been such a remarkable focus on the ALS providers. And the challenge is without EMTs, we don't get ALS providers. We need functioning EMTs with skills because they're going to become the best paramedics. So somebody going from EMT class this year, next year, I'm going to jump into a medic class, and then realize they have motion sickness when they're in the back of the ambulance is not the right pathway. What we always have to remember as an ALS provider is what makes a good ALS provider is our basic skills also. Because when those ALS skills don't work, we only have one other thing to fall back on, and that's our BLS skills. If I know I can do a good BLS airway, if I miss an innovation, I know I can do a good BLS airway. And take the emergency out. There's been so many times on opioid overdoses, as long as the emergency's over, once I figure out that I can do it, once I get to that point, then everything else is cake. EMS Con Ed classes, we had a lot of questions on that. I provided the data on the amount of Con Ed classes. I know there was a lot of concerns about so much online stuff, but we can't get people to show up in person to classes. What is there, 11 people online today?
Nobody, I can with this week here.
29 online. And I know it's convenient, and this is some of the downside. I love in-person classes because it's the only way I get uncandid conversations and that small talk. Equivalent, our in-person classes are equivalent to golf course talk for doctor terms, you know. Where people are open to saying what they really mean. And we, you know, and this is what, the Con Ed sponsors and virtual opportunities are just so rampant. We did the refresher class in Percy, and I think we had 10 people. 10 people there, maybe it was 15, but like 7 of it was all. There was a concern about 911 utilization. It's so funny because I got it from 2 different people. I got it from a non-emergency agency, and I also got it from an emergency agency, somebody that predominantly does 911 calls, about the utilization of 911. These places are kind of stuck in a roundabout way. There's not many non-emergency transport services, and when somebody has what seems to be a minor to us that can go by, sometimes we're human nature. What can I do fastest? You know, I can run to Walmart, or I'll call Amazon, and they'll have it here tomorrow. You know, I think that's some of our challenges. Our 911 center cannot refuse to go to a 911 call. You know, I know it stinks, and I'm sure I've looked at this so many different ways where people complain about, listen, I was there. Everything everybody's complained about, I've complained about at least one time in my life. You know, where you go to a nursing home and we're skilled facility and say, oh, I can't believe they're calling us for this, you know, and then it is what it is. They can't get somebody, and the person needs to go to a hospital, whether it's super acute or not, or minor, it happens. And then at the same note, they stop calling forever because we treated them horribly. And so now they're doing emergency calls, and now we're mad about that too. Again, we can't have both. I don't know. I think this is going to get worse as the EMS work more challenged. And just like I advocate for our 911 services to our municipality about giving consistent, I say the same thing to our hospitals and our skilled facilities. If you want to guarantee, EMS is the worst business to get into. You can't say to somebody, I got a deal to do. Say, it's going to cost you about $1 million a year, but I can't guarantee how much you're going to make back. I can't even guarantee you break even because you only get reimbursed when you do when you move a patient. It doesn't account for anything else. So if you're not moving people, it's kind of it's a losing business. And even when you move, the cost to collect on that money is even more challenging.
Just take a minute to have everybody check your speakers and mute them out.
So again, dispatch types, a lot of our dispatch in the one card. And I'm almost positive.
Jason's decided you're done.
Wow, I got the hook.
Thanks for your efforts.
I'm almost done, I promise.
I sent him a text. I said, and
I think it was finish him. You're kind of a Mortal Kombat kind of guy.
I was being nicer. I'm from Leathertown, not Bristol, remember? We're cool.
Why has it got to be Bristol?
Jaded.
Welcome back, Larry Lewis.
Our dispatch types are kind of grouped together. And I think even if you get an abdominal pain, you get dispatched. Sometimes when you look at the text, it'll say back, it's for the back pain. They're all on the same dispatch card. And I think, I haven't looked at a new CAD when it prints out, if it still says dispatch type, back pain and abdominal pain at the same time, that I'm not sure about, or it just might say abdominal pain. It's not a miss, but the resources are the same, the card is the same. It's not inaccurate information. It's what they relay to you on the other side is important. And I'm open for any questions.
But Larry, just to point to the dispatch comment, or, that question that comes up, we get it often, right? Is the dispatchers have a complex job, they're held to very clear requirements for a time frame, and then honestly, often will over triage, which is acceptable. We do it in a lot of things in medicine. And the best thing is feedback, right? If we can give feedback, hey, if I see a trend of something, we can look at that. But much of what we do in this area is really around making sure that the assets get there in a timely fashion. Much more complicated knowing whether that should have been an ALS dispatch or a BLS dispatch, and moving forward an IALS dispatch. Certainly feedback is welcomed and appropriate, but I think we have to understand that everyone's trying to row in the same direction. So,
And I would welcome and invite anybody to contact the communication center and go up and sit down with the call taker and hear how they do it and how they can see. And it's not an experience. It's a completely different point of view.
I can only say, I went to the resuscitation academy for the communication center a few years ago. And it made me realize it's another job that I don't want to do, is be a telecommunicator or 911 dispatcher, because you're at the mercy of whatever the caller is reporting and trying to extract information out and get the right resource and dispatch it all in a short period of time. So I don't think it's intent, but again, the concern is that they were misdispatching. And do I think there's some off dispatches? Absolutely. But our dispatch center does, just the EMS side does over 65,000 dispatches, and it doesn't include the fire and police on the other side. And I'm open for questions, answers. I know, but this is just my part, and then we'll move into the wedding part. Nothing?
Ryan Egan?
Hey, real quick, with the talk of getting back to in-person Con Ed, one, I want to say Ian did a really great job with the class last month. I really enjoyed it, and I was honored to be able to speak myself. But the Morgan Bach doing the the American Sign Language and doing the post-rock stuff was really interesting. I'm glad we're doing more of that stuff. The other thing is there a chance of the county command review coming back now that we're in a pre or a post-COVID environment?
well, COVID didn't end that. Agency lack of participation and interest ended that.
Is that, I must have missed, I guess the timeline was too close together. I assumed I had attributed it to COVID.
It was an unfortunate coincidence. We were happy to do it and enjoyed participating in it, but to do it all on our own was an extremely logistically impossible task without the outside participation.
It would require agencies, their medical directors, their leadership to say, yes, we feel there's value, we want to do this.
And I know it's a logistical night, like it's very difficult for you guys, and I've always appreciated the work you put in, but I do feel like it helps maintain a standard for quality of care. Like I kind of hate the fact that it's gone, but I guess it's going to come down to individual agency medical directors. It's just that simple.
Yes, on all fronts.
So I was just curious if they might be coming back or not. That's all.
We encourage you to talk to your administration.
If a core group of agencies wanted to look at that, we could have that conversation again. I think we saw the value and we believe it's the easiest path for a medical director to meet the obligation of the regulations for credentialing. Not the easiest, the most important. It's actually not only easy, it's consistent. And instead you have potentially multiple agencies redoing the same thing for the same staff member, so. And I can say in our organization, we have several of them planned for the upcoming 6 weeks.
Sure.
Got, it's not about that. I just have a comment. It's mine. It's not, doesn't represent any organization or anything like that, but I think that, this is the forum, providers, leadership. I don't remember in my 27 years in this region as many ambulance crashes as we had. So I personally would just like to say that I think everybody should be checking themselves, the number of hours you're working continuously, leadership scheduling these. I mean, and these are some pretty substantial crashes. We all share providers. We know this, and eventually somebody's going to start asking why. So that's just my opinion. I know a bunch of chiefs. We've discussed this. I know there's providers on this call. There's chiefs on this call, and I think it's something we all really need to think about why these have happened. And these were not fender benders. These were substantial.
I'm going to just tag on from a data point of view and a protocol point of view, or a guideline rather, of lights and sirens use. Some of these, from a documentation point of view, without being with the patient, I can tell you don't meet lights and sirens criteria. And it was probably a contributing factor in some of them from the information I was given.
I think some of it is we still have an excessive use of lights and sirens. I think the other part that we really have to think about, this is a point in time where we have some of the least experienced providers on the street over the past probably 20 or 30 years. We have a lot of newer people. They're coming in as career EMS providers, and they're relatively new. They haven't had that extra time. Like when we had a predominantly volunteer system, you would never get signed off to drive an ambulance in less than a week. It would be 100 transports. You need to do 1,000 different things. You need to see a squirrel in a tree 4 times, and have it documented, get its name and stuff. The requirements were much more rigid. But I think as we move through, and even when I looked at some of Jason's stats, with innovation and things of that, we don't have the same skill experience that we've had in the past, so, and now more isn't always better, where the more is better is more experience. And that's seeing more patients, taking care of patients and stuff like that, and gaining that experience. We don't have that same experience level as we had in the past. So I think you'll see some of this. On another note, if I now in my new position, I get to see a lot of crashes. So the police departments have almost as much crashes as us, which is even scarier. But that on the same note of that is I sit on a strategic police planning committee, and they want a place where they can do EVOC re-credentialing on a regular basis, because that's one of their biggest liabilities, as it is one of our biggest liabilities. In having that training. So I always circle that because it's so cool. When I look at that, is that something that will expand all 3 public safety disciplines, or traditional public safety disciplines, that rechecking driver stuff. So I think, there's much more now than there was before, but I think there's a lot of factors involved with it. But I think we got to take some sort of personal accountability. A lot of places have the driving monitoring system. What causes it? And we got to really get rid of our policy of grandeur. And again, I've experienced it. And when I say a policy of grandeur, is everybody needs a spotter when they're backing up. But it seems like you only need a spotter when the building rear ends the ambulance, because we've never backed into the building. It's always been the building's fault. And I think that's what we really have to start thinking about. And it starts at the leadership. If we're not going to hold our providers accountable for not having that spotter when they don't crash, then there's no point in having it. I think it's just a negative effect on our providers.
There are 3 absolute truths in EMS: that epinephrine saves every cardiac arrest, that intubation saves lives, and that lights and sirens save time. And those are all not true. But those are absolute truths for many of us in EMS practice. And the literature is crystal clear. Doug Kupis, the previous Commonwealth Medical Director, the incoming president of the National Association of EMS Physicians, has been a dire advocate of prudent use of lights and sirens. Not elimination, but prudent use. And we don't use them prudently. Response, there's arguments there. You don't know the full detail, but certainly once you have a patient in your clutches, you know when you need to use lights and sirens. And we've all seen too many accidents, near misses with their use. I think it's almost probably indefensible on the transport arm using lights and sirens unless it is a true life threat. On the response side, it becomes more complex because of not always understanding what you're going into and the risks to the patient in an uncontrolled environment before you get there. But even there's a lot of opportunity. The literature is crystal clear. The time savings is relatively small, never been proven to have tremendous benefit, except for a few very key cases.
Any other questions? All right. My next thing is, as with the Bureau, is we've had leadership changes within the EMS office and kind of changed our structure. So it's only been 6 months. I've probably introduced him only a handful of times. He's kind of gotten thrown into the fire in a roundabout way. I'd like to introduce Chris Woods, who's Deputy Director of the EHS office, and that structural changes. He fills the responsibilities of the Regional Council Director. The good part is through these transition, we kind of have a pseudo succession plan. I'm still at the office. I'm still part of the office. I still help out with the office. And as we move forward, these changes are going to come about, and change is always difficult. Most of the providers have been stuck with the same policies probably, and the way we've done things for this last 30 years. I don't know. Is it 50, Wayne? Wayne's in the room. He'll know if it was 50.
At least 40.
So again, I'd like to transition to Chris. He's still finding his way. He's been barraged with a lot of stuff and things that he never thought the EMS office did, and our involvement. So, Chris.
Thank you, Larry.
Sorry.
Use your words.
Thank you. Thanks, Larry. For those of you that don't know me, my name is Chris Woods. Most of you probably know me by my nickname of Woodsy. So before I delve into the presentation, I'm just going to give you a quick overview. I'm going to share some information personally about myself, professionally, educationally, and then one of the questions I always had at these town hall meetings is, what does the EHS office do? I'm one of those that are guilty of that kind of thought. We kind of just hung around Ivy Land and didn't do much. And much to what reality has been for me over the last about 100 days is they don't do what I didn't think they did. They are very busy here. So, and then I'll get into some of the assets that we have at our disposal that we're responsible for equipping and maintaining and deploying. So a little bit about me. I was born and raised in Northeast Philly. My mother currently runs St. Mary's Home Care. My father's a retired Philadelphia police officer. My brother, in one picture, graduated from boot camp at Paris Island. He's currently a paramedic down in Philly. And I have a sister as well. She does retail and volunteers at a fire company down in Bristol. I live in Abington with my wife and 2 stepsons, and I have my first child due in January or February of next year, depending on when he wants to make his appearance. In my free time, you can find me, watching sports, fixing cars and trucks, hunting, fishing, and delving into some Native American culture. Professionally, I got into EMS by accident. I started running a fire company in Bensalem back in 2000, and they offered a live-in program. But part of the live-in program was you had to have your EMT. So at the age of 16, I went to Levittown for my EMT program. I kind of fell into that trap. I started working for transport companies because I was under the age of 21. I couldn't get hired. So it was kind of restricted with where I could work, the hours. So as I kind of aged a little bit, I got into volunteering with Sac Alarmers and eventually got into working EMS in Bucks County full time. Over the last 21, 22 years, I worked at several agencies in Bucks County. Some in the rural parts. I spent about 3 years where I worked at Trenton EMS. So I kind of have some varied experience as far as what I bring into the office. Part of what that was is in 2008, I was deployed with the strike team in Trihampton Rescue Squad to Hurricane Gustav in Louisiana. And then in 2012 and 2013, I decided, I'm going to take the leap. I'm going to go to paramedic school. Sanford Brown opened a campus in Trevose. Went through the paramedic program. I was engaged at the time, so it came down to taking the test. I passed the psychomotor without any issues. I had a lot of issues with the cognitive exam, and with me being engaged, it came down to getting married and buying a house or paying for the refresher. So I was promoted in 2015 and 2016 to leadership positions, handled anything from scheduling, recruitment and retention, some clinical care, a little bit of QA, onboarding, and some special operations as far as the South Central SWAT team, where I served as one of the tactical EMS providers for a few years. Right before COVID started, I decided that I wanted to get my bachelor's degree, and I enrolled at Columbia Southern University in their bachelor's of public health administration, which has a large concentration in emergency services management, where in 2021, I was inducted into the National Society of Leadership and Success. So moving into my first 100 days, I started with the EHS office on June 20th. The first few days were kind of just getting tours of the county, the facilities, the people, the various departments that we work with, and kind of just getting to know what the overall role and mission of the EHS office is. I met with everybody in our office to see who does what, and we'll kind of delve into that here in a couple minutes. Some of the things I've been working on is, like Larry had mentioned, getting some of the stuff on paper that we are responsible for doing. So we've been creating some policies and procedures. We handle our scheduling. We always have somebody on call 24/7, 365 that can respond to incidents, phone calls. As Dr. Widra mentioned, if you need to contact us when you have an exposure, we have somebody there to handle that. And then we kind of delved right into preparing our budget for 2024 and forecasting our budget for 2023. One of the other things that we've been working on both individually as well as our entire office is various training. One of the requirements for us, because we do fill an emergency management role, is our Pima County associate level, and then several members of our office do various functions within the special operations team at the county level. And that's stuff we'll touch on here in a couple minutes as well. Some of the things that I have very little experience with is data mining. And the last probably 2 weeks has been being fed from that fire hose of all of the statistics that Larry shared with you, as well as some of the information Jason will share coming up here soon, as well as our medical advisory committee and our health advisory council. One of the goals that we had established before I came into the office was our physician response unit and getting that unit licensed at the BLS level. the extent of my experience with that has been, hey, we have our triannual inspection coming up. Here's the Department of Health's checklist, go into the truck and figure it out. This has been everything from policies, procedures, the CLIA waivers, mobile laboratory waivers, and just various paperwork, either with the Department of Health or the Department of State. To throw that in the mix, we had the Upper Makefield flooding incident that our office provided some resources and staffing from. And it was an opportunity to learn the emergency management side of the house from a different perspective of when I responded to Gustav in 2008. So we kind of got thrown right in doing unmet needs requests through LevEOC and working with various stakeholders to move equipment and personnel throughout the region. And then the last point is there is various stakeholders at the state and regional level, as well as the local level, that we've had meetings with. Almost once a month, I've gone out to Harrisburg to meet with the Bureau of EMS, PESH. There's been regional directors that attend these meetings, legislative advocacy groups, politicians, and we actually have more coming up. I'll be in Harrisburg. I'll be out in Harrisburg again next week for another meeting, and then several of us from the office have another meeting at the end of the month. So some interesting facts that I found out in the last 100 days as it pertains to EMS in Bucks County. So we have a landmass of 622 square miles. 8 of the 54 municipalities are rural, and as Larry had mentioned, we met with 8 of them municipalities recently. Our population, 646,000 people. Our office, we kind of help with the 52 licensed agencies. And as you can see on the screen, 16 are 911, 26 are QRS, and 10 are private transport. I was kind of taken back by the 1,882 EMS providers that are in the county. I'm not sure how many of them are active or inactive. That's just when you look at the log and you look at the people that you run into at the hospital, it always seems to be the same people. And to see that number pop up was kind of surprising to me. Moving into our hospitals, so we have 6 medical command facilities, 6 hospitals in the county. We have they're all primary stroke centers. There's 1 thrombectomy capable, and there's 2 level 2s. As of today, there is now 4 training centers in Bucks County, one of which is ran by our office as far as the EMT training. We have our CISM team that Michelle kind of spearheads. That's available 24/7 to agencies and providers. That is a simple phone call to the radio room and talk to the dispatcher, and Michelle will reach out. And then recapping what Larry had said, our call volume last year was the 65,000 dispatches and 40,000 transports with our average response time. So many of you are probably scratching your head, well, what does the EHS office do? So this is something that I've asked and now I know, and I'm going to share some of that with you. So we do have a warehouse in Bucks County that houses a bunch of equipment that can be requested through the office, through the on-call person, or through LevEOC. So part of what we do is help facilitate the storage of the equipment. We circulate supplies that have expiration dates and whatnot through there. We do fill an emergency management role. We recently conducted a drill where we filled in parts of the incident command structure. Part of what our mission is filling unmet needs at EMS agencies, and if necessary, we can conduct damage assessments or fill roles in that structure within incident command. Some of the things that we do as far as the special operations team, not everybody, but a handful of us are variously trained in either hazardous materials, doing some of the dive and water rescue, the urban search and rescue team, as well as the drone team. We also can provide incident support management. If you have a very complex incident, you can reach out to the radio room and have the on-call representative either request a phone call where you can have them respond to the incident. Along with that is also the physician response team. Dr. Wydrow, Dr. Wong would work out as far as our on-call representative. If you needed a physician response, we do have a vehicle that is equipped, as well as the physicians themselves coming out to provide anything from advice all the way up to actual clinical care if necessary. We have our Emergency Health Services Advisory Council, which is required under the rules and regulations. This is something that I would be spearheading and working with the council and their executive board. And then we have our Medical Advisory Committee, which between Dr. Wydrow and Jason would have with the various hospitals and stakeholders, EMS agencies. We ensure the compliance piece for the rules and regulations. This is where the safety inspections and the triannual inspections for licensure come in, as well as our medical command facilities. And then we have our Southeastern PA Regional Task Force and our hospital coalition partners, that there's various working groups that we help with various projects, running exercises or drills, be it tabletop or live action drills. Jay, can you one of the things that we also handle is our certification, licensure, and continuing education. Typically, this is something that Michelle would help with, running the EMT classes, and then anything with the Con Ed. We have our education institutes. We're responsible for doing inspections and ensuring that they're compliant, as well as the medical command physicians and facilities. We advocate for our EMS agencies, providers, and our municipalities. In the last 6 weeks, I think we've gone to 2 or 3 different meetings with municipalities on sustainment and financial partnerships. And then we obviously interact with various stakeholders across the board, be it nursing homes, hospitals, healthcare organizations, government or public safety agencies. As Larry mentioned, we have some recruitment activities that we get into as far as promoting the EMS profession. And then we do our triannual inspections, safety inspections, and medical command facility inspections. And the more I'm here, the more I'm uncovering as far as what our office actually handles. So our organizational chart, we'll kind of delve into this a little bit more in depth here as we go. Larry is taken over as the Director of Administration. Part of what he does is oversee our office, as well as several other offices within the Emergency Services Division. And then under me, we have Kim Dickin as our administrative assistant, Dr. Wydrow. Jason is handling QA, QI. Gina's our field rep. Michelle handles our education and training centers, as well as our SISM team. And Ian does training and recruitment, and also handles the EMS instructors within our educational institute. So some of the roles and responsibilities, this is something that almost daily we have somebody calling and asking who handles certain things. And this is just a very brief, I'm sure I'll hear it from the rest of the team later if I've missed something. This is just a brief of what each individual person handles. So Ian will set up our EMR and our EMT classes, some of our Con Ed classes, such as our refresher class that we're having this Friday. We have another one scheduled next month, and we're working on more for next year. Anything from the equipment, the signage, everything. Ian also teaches first aid, stop the bleed, and CPR for all the county employees. And he will attend job fairs and career fairs, do various recruitment activities. Michelle, she does initial and renewal certifications for all levels of providers, including our medical command physicians. And then she sets up our psychomotor testing for with Pennsylvania National Registry. She handles the content by endorsement. If you have EMS registry access issues, typically Michelle is going to be the go-to for that, and as well as the SISM team. Gina, she's the field rep. She will handle anything licensure, whether it's an EMS agency, medical command facility. She will do the spot and or safety inspections at the various facilities in the county. She also handles our social media, the leave behind Narcan, your command forms, and then if your agency requires block validations, she'll run the block validations. And she also works with the radio room, the CAD and the GIS specialists upstairs to do that. And then if your agency has experienced an accident or an injury, you would file your reports with Gina. Jason handles all the data collection, data analytics, data mining. He does the PCR review for compliance and protocol deviation. He also handles a lot of our emergency preparedness. And then he's the liaison for the medical advisory committee. And he also handles a lot of our report preparation. Kim, she handles anything with our budget, accounts receivable, accounts payable, the ARPA funding, finances. She has spreadsheets for just about everything, which has been a big help with learning the ins and outs of everything going on. If necessary, she could help with EMS registry access in the event Michelle's not available, and then she handles the payroll for our department. Dr. Wydrow handles everything with our clinical care, medical advisory committee, sits on the health services, emergency health services advisory council, as well as the EMD cards, as we had seen earlier in the town hall. So what do? I oversee everything within a department on a day-to-day basis, as well as filling that regional director role. I am doing reports. I am working with internal and external stakeholders. You name it, I'm doing it. Training, education. We kind of have group discussions about all of this. So the more I'm here, the more, I'm being fed from that fire hose. There's times where it's very overwhelming, and there's times where it's very rewarding. And then Larry oversees various departments. Larry has taken me under his wing as a mentee and mentoring me, providing me the opportunities to learn the things that he needed to learn. It took him 3 years. So here we are. And he reports to Audrey County, who's the director of emergency services. Position response vehicle, if it's needed to respond, you could request it through the radio room. The radio identifier port is Special Service 801. It's there to help supplement the patient care for extremely complex special operations events. It has some of the capabilities is the vital sign monitoring, ultrasound, IV pumps, if necessary, field amputation. And then we can collaborate from an incident management perspective if that's also required. We have the UTV, which can be requested as either an emergency response or for a standby event. You would have to reach out. Typically, this is something that Jason would handle. If it's an emergency management type function, you could reach out through your local emergency management coordinator and request it through WebEOC. This also has seating for 7 people. It has a Stokes basket, and this is definitely a deployable asset if necessary. The pod and the MCI trucks, there's 2 of them, one in Ben Salem, one up here in Doylestown, and then we have the pods and then the MCIs. So they can handle, I believe, if it's not making mistake again, it's what, 100 or?
The pods are set up for about 100 patients each, and the bread trucks are 50.
Right. Thanks, Jason. They can be requested for either MCI response. The radio room may ask you if you need it to respond for MCI incidents, or to be requested for a very large event. We have our mass care trailer that's housed down at Tyndall Middletown. This is basically a storage unit that has basically a mass care facility stored within it that can be deployed and set up if needed. I don't know exactly how many patients this can treat. I'm thinking, what, about 40?
I think 40 is what they're set up for.
So this could be requested through the radio room, but there's some other stuff on the back end that has to be worked out by our office through PEMA. And then the emergency management role. So these are just some specifics as far as what we do. So we can staff the emergency operations center, some of the training that we have to go through as far as the Pima County associate professional level training, which takes anywhere from 1 year for the associate level and 3 years for professional level, doing damage assessments, filling them unmet needs with resource requests, and then filling in roles within incident command structure. Does anybody have any questions?
Larry or Chris, any update on the state medical director, I'm sorry, the state director position, the EMS director position for the Bureau? Are there any updates on the timeline of
There
that?
was 100 applicants for the position, and they've done round 1 of interviews. And that's what I've heard. They're going to hear some more next week.
And
Yes, if nobody has anything, we can wrap up.
Just see if there's any final question for anything or anybody. Is there any questions out there for anybody from, with regards to the EHS office or even the county?
Nothing in the chat either.
Brian, you don't have anything? One last question?
I'm sure I can think of something if you give me a couple minutes, but no, not right now.
We'll adjourn before you think of it. All right, I think we can adjourn. If nobody has any questions, if you're not comfortable talking in front of a group of people, you can shoot any of us an email and we'll work through it. All right, thanks, everyone.
thanks for hosting.
Everybody have a good day.
Thank you.